Good morning, everybody. So let's get started with chapter 17. I'm going to go ahead and share my screen and we'll delve in. So, chapter 17 deals with the blood, and we are going to talk about the understanding of anatomy and physiology of blood types of blood and how it helps you to advise patients on activities to prevent blood clots during hospital stays. And we'll delve into this as to why that's important. Okay, so blood, remember, is one of our types of tissues. More specifically, it is a connective type of tissue and it's fluid. And blood is the life-sustaining transport vehicle in our bodies. So blood is going to be responsible for transporting any type of nutrient, hormone, gas, waste products. It's the transportation method, the vehicle that our body needs to allow for things to flow through our bodies. So functions of blood include transportation, regulation, and protection. So in terms of transportation, you might ask yourself, so what things are we transporting in our blood? Of course, we're transporting oxygen, nutrients. We're going to transport waste products from our cells, so thinking of CO2. We're going to transport hormones and proteins and all of those things. So anything that needs to be delivered to our cells or taken away from our cells will be transported through our blood. In terms of regulation, we're going to regulate our body temperature. So we learned from 168 that our skeletal muscles contract, and in the process of contracting, they produce heat. So that heat is going to circulate through our blood to keep our body temperature stable. Also, we're going to help to regulate our body's pH by allowing for our blood to transport buffers. So remember, from 168, buffers are going to be a weak acid or a weak base that will help to stabilize our body's pH. And remember that the most common buffer that we use in our bodies is going to be bicarbonate ions. And then lastly, we're going to regulate the adequate volume of fluid that's going to circulate through our bodies. So blood's going to help to do that. And then lastly, in terms of protection, you might have thought to yourself like, well, how does blood protect us? And it's not so much the actual composition of blood that's going to protect us, but it's going to be the circulation of materials that blood's going to allow for protection. So number one, blood is going to help to prevent blood loss by circulating platelets, so that when we do have an injury to occur and we need to repair that, blood's going to allow for platelets to circulate to clog a break in a vessel. In addition to that, blood is going to allow for the circulation of antibodies, other types of proteins that will complement our lymphocytes to aid in protection against pathogens, and then white blood cells. So like I said, blood's not necessarily going to protect us in terms of its composition, but for the materials that it allows to circulate within it. Like we said before, blood is going to be a tissue that we have in our body. It's the only fluid tissue that we have in our body, and it is a connective tissue. Remember that the matrix is the non-living portion of the connective tissue, and the matrix for blood is going to be our plasma. And the cells that we find within our blood are formed elements. The formed elements that we find within our blood are going to be erythrocytes, red blood cells, leukocytes, white blood cells, and then platelets. So when you are looking at blood and the composition of blood, we can take a sample of blood, put it in a test tube, spin it down in a centrifuge, and then we can see the distribution and the composition of blood. So the erythrocytes are going to be the heaviest portion of blood. They're going to represent about 45% of blood, and they're going to be the bottom portion of a blood sample. The hematocrit, you do want to know this. This is the percent of blood volume of that is the red blood cells. So if we were looking at someone's hematocrit, what we're looking at is what percent of a whole blood sample is going to be red blood cells. And in terms of white blood cells and platelets, that's going to represent less than 1% of a whole blood sample in a normal, healthy adult. And that's true. If I'm normal and healthy, I shouldn't have a whole bunch of white blood cells in my blood, right? Versus if I'm sick and I go to the doctor and they take a blood sample, if they see a ton of white blood cells in my blood, then that's indicative of maybe an infection or something like that. So in a normal healthy adult, if we take a sample of blood, we should not see a whole bunch of platelets and white blood cells. And then lastly, the last portion of a whole blood sample is going to be plasma, which plasma is going to represent about 55% of a whole blood sample. So if we look at this diagram here, we see that we're taking a sample of blood, we put it in a test tube, spin it down in a centrifuge, and then this is what we'll see after spinning it down. So about 45% of this whole blood sample is going to be our erythrocytes, our white blood cells, our red blood cells. This buffy coat is where we're going to find our white blood cells and platelets. And as you can see, it's very small in a healthy adult. And then the largest portion of the whole blood sample is going to involve plasma. Now, some physical characteristics and in terms of volumes of blood. When you look at blood, blood is going to be sticky. It's going to be opaque in color, and it's got a metallic taste. You probably have tasted blood some point in your life because you could have, bit your tongue, you could have bit your cheek, you lost a tooth, so on and so on. In terms of color, the presence of oxygen is going to affect the color of blood. So if you have high levels of O2, then blood is going to take on a more scarlet red look, a brighter red look. If there's low levels of O2, then blood will take on a very dark red look. The pH of blood, we should remember this from 168, is between 7.35 and 7.45. And remember that our blood pH cannot veer from this range really at all without us seeing some adverse effects from it. Blood makes up about 8% of our body weight. And in terms of volumes, I'm not going to test you on this, but this is there for you if you're just interested. In terms of volumes, for males, blood is about 5 to 6 liters. For females, it's a little less, 4 to 5. So let's look at blood plasma. Blood plasma is going to have a straw-colored look to it, and it's going to be sticky. It's about 90% water. So 90% of plasma is going to be water. And the other composition of plasma are going to be these dissolved solutes. So we find in plasma nutrients, gases, hormones, waste, proteins, and inorganic compounds. Plasma proteins are going to be the most abundant solutes that we find in plasma, and they remain in the blood. They're not taken up by the cells. So these plasma proteins are beneficial to blood because should some pathogens, viruses, bacteria get within the blood, there are plasma proteins there that can potentially, think of antibodies, which is a protein. But those are there to potentially help to protect blood itself. These other plasma proteins do have various functions. The proteins that we find in plasma are primarily produced in the liver, and one common plasma protein is albumin. It makes up about 60% of the plasma proteins that we find in plasma, and it functions as a carrier of other molecules, so it functions as a transport protein. It also acts as a buffer for blood, and it contributes to the plasma osmotic pressure. Here's a table that just shows you a composition of a composition of plasma and the substances that we find within it. I do want you to know the different types of solutes that we find in plasma and a quick understanding of what they do. So this chart is a great chart to study because it'll tell you, we find albumin in here, and albumin represents 60% of plasma proteins. That's about as much as I want you to know for this particular section. So this is a really good chart to study. Okay, in terms of the formed elements that we find in blood, like we said before, we have red blood cells, white blood cells, and platelets. Only white blood cells are complete cells. Remember, red blood cells do not really have, they don't have a nucleus. They don't really have any organelles, hardly, compared to what we normally find in a fully functioning cell. Platelets are actually just parts of a larger cell that are broken off. And so the only fully functioning cell that we find in terms of the formed elements are going to be white blood cells. And most formed elements survive in the bloodstream only a few days, and most blood cells originate in bone marrow and do not divide. So we know that red blood cells cannot divide because they don't have a nucleus, which means that they don't have DNA, so they can't divide. This is why if you go to donate blood, they will advise you need to wait roughly 120 days or 4 months so your body can replenish the blood cells that you lost, because our bone marrow is going to have to make more red blood cells because the current red blood cells that we have do not readily divide like our skin cells. And same thing with platelets. So here we have a diagram just showing us a micrograph of what red blood cells and white blood cells and platelets look like. So here we have examples of red blood cells. Here we have some examples of white blood cells, and then these small fragments are our platelets. And here's another micrograph. So this is from a scanning electron microscope where you're able to see things on the outside, and then this is a standard micrograph of what things look like under a microscope. You definitely will be seeing these figures in lab if you haven't already. Graphs like this showing us our red blood cells, which are going to be the pink circles. We have different examples of white blood cells that we see here, and we know that they're white blood cells because they have a nucleus, which is going to be that darker purple area. And then these little dots that we see here are examples of platelets. So let's talk a little bit more about red blood cells or erythrocytes. So they're very small in size, and their biggest function is going to be gas transport. So we know that red blood cells are going to carry oxygen, and they will also carry a little bit of CO2 as well to and from our cells. They have a biconcave shape. They do not have a nucleus, and there are no structures within the cell. That is so that our red blood cells can be flexible, so that when they're traveling through our capillaries, these very, very tiny vessels, they're able to bend and manipulate themselves so that they can get through to the designated cells. Red blood cells are going to be filled with a protein called hemoglobin. Hemoglobin is the actual molecule that's bound to red blood cells that will allow it to carry oxygen and CO2. And they contain plasma membrane proteins called spectrin. That's one of the plasma membrane proteins that allow for the red blood cell to be flexible so that it can change shape and manipulate itself so that it can squeeze through very small blood vessels like capillaries. Okay, so 3 features that make the red blood cell efficient for gas transport. Number 1 is its biconcave shape. So the shape offers a huge surface area that is relative to volume for gas exchange. So this biconcave shape makes it very easy for oxygen to diffuse from the red blood cell into our cells, and also allows for the red blood cell to pick up CO2 from the cells. Hemoglobin, like I said before, is the protein that oxygen molecules will actually bind to. And that makes up about 97% of the entire red blood cell. And like we said before, red blood cells do not have structures like mitochondria. So any type of energy that's going to be produced is going to be through an anaerobic process because we do not have mitochondria. So the great thing is that the red blood cell will never consume oxygen because the only way that it's going to be making energy is through an anaerobic process that will not require oxygen. Here we have the diagram showing the biconcave shape. So based on this dome shape and the surface area that is generated from the shape, it makes it very easy for oxygen and CO2 to diffuse to and from the red blood cell. So like we said before, hemoglobin is the protein molecule that is attached to the red blood cells that is responsible for oxygen and CO2 binding to it. Hemoglobin consists of a red hemipigment portion, and then the hemi portion is bound to the protein that has the more globulin shape. Globin is composed of 4 polypeptide chains, and remember from AMP1, when we're making a protein, some of our proteins have to go through all 4 structural shapes or stages to be fully functioning proteins. So this is an example of that. The hemi portion is the pigmented portion that's bound to the globulin chain. So the hemi portion of the hemoglobin molecule is what gives red blood cells the red color. And also each hemi's central iron atom binds to one oxygen molecule. So here we have a diagram showing us the structure of hemoglobin. So we see 4 different polypeptide chains that are bound together to make this protein. Okay, so each hemoglobin molecule can transport 4 oxygen molecules, and each red blood cell contains 250 million hemoglobin molecules. So 250 million times 4, that's a whole lot of oxygen that one red blood cell is able to transport. Oxygen loading in lungs is going to produce oxyhemoglobin, which is going to be a ruby red color because we're filling it with oxygen. Oxygen unloading in tissues is going to produce deoxyhemoglobin, or a reduced hemoglobin load. So that's going to allow for blood to have that more dark red color. And then carbon dioxide loading in tissues, about 20% of CO2 is going to bind to hemoglobin molecules. The other portion we'll talk about in a little bit. So hematopoiesis is going to be the process where we form all blood cells, red blood cells, white blood cells, and platelets. This is going to occur in our red bone marrow, and it's composed of reticular connective tissue and blood sinusoids. So in adults, the red bone marrow is found in the axial skeleton, our girdles, and also in our humerus and our femur. The hematopoietic stem cells, we call those hemocytoblasts. They are the stem cells that are going to be the origin of our formed elements. And hormones and growth factors are going to work together to push the cell toward a specific pathway to determine if it's going to be a red blood cell, a white blood cell, or the formation of a platelet. Okay, so here we have the stages of erythropoiesis. So erythropoiesis is the actual process of forming red blood cells, which should make sense because erythrocytes are the formal term for red blood cells. So erythropoiesis, the formation of red blood cells. This whole process takes about 15 days, and we'll go into the different stages. So we start off with a hematopoietic stem cell, and this stem cell will transform into a myeloid stem cell. Then the myeloid stem cell will transform itself into a proerythroblast. The proerythroblast will divide many times, transforming into a basophilic erythroblast. And then the basophilic erythroblast will synthesize many ribosomes, which will stain blue. Then we go into a polychromatic erythroblast, which will synthesize large amounts of red-hued hemoglobin, and the cell will now begin to show pink and blue areas. So then we transition to the orthochromatic erythroblast, which will contain mostly hemoglobin, so it appears just pink. At this point in the process, this is when the red blood cell will eject and get rid of the structural portions of the cell, because at this point we still have mitochondria and ribosomes and so on and so on. So we're going to eject these structures. The nucleus will degrade and break down, and this will form the concave shape of the red blood cell. So now we're starting to mature a bit to be a fully functioning red blood cell. Then we will transition to a reticulocyte, where this still contains small amounts of some structures. And then finally, the reticulocyte will mature into a mature erythrocyte. So this occurs in about 2 days, where at this point, all structures inside of the red blood cell will degrade, and we will have what we consider to be a mature red blood cells. The reticulocyte count indicates the rate of red blood cell formation. So if we were ever concerned that, okay, your body's not making red blood cells efficiently, then we can look at the process of we can look at how long it takes a cell to go from a reticulocyte to being a fully functioning red blood cell. Okay. So in terms of regulation and requirements of erythropoiesis, too few red blood cells lead to tissue hypoxia, which means that it's extreme oxygen deprivation. Or we can also have too many red blood cells that will increase blood viscosity, making our blood very thick, which can lead to blood clots. We have more than 2 million red blood cells that are made in our bodies per second, which is astonishing. And the balance between red blood cell production and destruction is all going to depend on hormones and our diet. So erythropoietin is the primary hormone that's going to drive the body to make more red blood cells. So Erythropoietin is always found within our blood in very small amounts to maintain just a basal rate of and a constant rate of replenishing red blood cells that we're losing. This hormone is going to be released by the kidneys. Sometimes it can be released from the liver, but it's normally released in response of tissue hypoxia. So whenever the kidneys, sometimes the liver determines that our tissues don't have enough oxygen, it will stimulate the release of this hormone. And so then this hormone is going to trigger our red bone marrow to produce more red blood cells. Okay, so what are some causes of hypoxia? So this can be caused by a decrease of red blood cells due to hemorrhaging. If there was a condition, for instance, let's say a person had a blood transfusion, but they were given the wrong blood, so they lost a lot of red blood cells because their self-red blood cells were destroyed from being given the wrong blood cells. That could trigger hypoxia. If insufficient hemoglobin that's found on red blood cells could trigger hypoxia or be a cause of it, because if we don't have enough hemoglobin molecules, then we don't have enough molecules for oxygen to bind to. And then also the reduced availability of oxygen. So if I am traveling to high areas, I'm in the mountains, I stop breathing, I have pneumonia, respiratory issues, things like that. All of these can be causes of tissue hypoxia. Okay, too many erythrocytes or high oxygen levels in blood can inhibit erythropoietin production. So erythropoietin causes erythrocytes to mature faster. Testosterone enhances erythropoietin production, which is why if I am a bodybuilder or I'm an athlete, I might want to take some steroids, because the more steroids that I take, especially if they are testosterone based, that's going to cause my body to make more red blood cells, which is going to have, it will allow my muscles to have more oxygen so that I can perform better. Obviously, we're not sitting here condoning that, but this is just to give you an understanding as to why athletes might choose to take steroids. This is one of the benefits of it, being able to have extra oxygen within your body so that your muscles can perform better. This diagram shows us a mechanism for regulating the process of forming red blood cells, and for time purposes, I'll skip through this. Once again, definitely go over the imbalances of red blood cell production, but for time purposes, I'm going to skip over it and move on. Okay. Like I said before, erythrocytes are not going to divide themselves and go through a process of mitosis because they don't have a nucleus. So they only have a lifespan of about 100 to 120 days. Old red blood cells become fragile and hemoglobin begins to degrade. So when they reach about that 100 to 120 day mark, our body's going to recycle them. So more specifically, our liver will recycle damaged and old red blood cells so that we don't have them circulating in our blood causing issues. Okay, I'm not going to go through the fate and destruction of erythrocytes. I'm not going to test you on any of those or any of this in detail, so I'm going to skip over it. But I do want you to know the life cycle, the normal lifespan of red blood cells and why our bodies need to recycle them. In terms of erythrocyte disorders, like I said, for time purposes, I'm going to skip over a lot of these, but I will address anemia. So anemia is going to be when our blood has abnormally low oxygen carrying capacity. That is too low to support normal metabolism of our cells. Because if you've ever taken a chemistry class, or you remember from Bio 168 when we were talking about the muscular system and we were talking about respiration and how we make ATP, a lot of those processes require oxygen. So when our body has insufficient amounts of oxygen, it's going to have a direct effect on our cells' metabolism. So some symptoms of anemia can be fatigue, dyspnea, getting chills, low energy, and so forth. And there's 3 groups that are based on cause. So we can be anemic because we've had severe blood loss. We can be anemic because our body doesn't produce enough red blood cells, or we can be anemic because we actually produce too many red blood cells. I'm sorry, too many red blood cells are being destroyed. So when we're talking about blood loss and resulting in anemia, that can be due to a hemorrhage, where you're rapidly losing blood. So maybe you were in a surgery, you had a child, some condition occurred where you're just rapidly losing blood at one time. A chronic hemorrhage is slight, but it's a persistent blood loss. So let's say you had a bleeding ulcer. So, you know, that bleeding ulcer is not going to necessarily be like a burst and, you know, you have this rush of blood, but it's a constant kind of leaking of blood. And the primary problem must be treated to stop the blood loss. If you have an iron deficiency anemia, this is us not having enough red blood cells that are being produced. This can be caused to a hemorrhage anemia, but it also can be caused by taking in low amounts of iron. So red blood cells are called microcytes because they're small and pale in color because they're not able to carry as much oxygen. And so they're not able to carry as much oxygen because they cannot synthesize hemoglobin because there's a lack of iron, and iron is needed to synthesize hemoglobin. So to treat this type of anemia, we would take iron supplements. Pernicious anemia is an autoimmune disorder that destroys the stomach mucosa that produces our intrinsic factor. This intrinsic factor is needed to absorb vitamin B12, and vitamin B12 is needed to help red blood cells to divide when they're being formed. So without B12, red blood cells enlarge, but they cannot divide, which results in macrocytes. So to treat this type of anemia, patients can take a B12 injection shot or or take a nasal gel. And this can also be caused by a low dietary intake of vitamin B12. So if you are a vegetarian, this might be an issue because we find larger amounts of vitamin B12 within our meats. Renal anemia, this is caused by a lack of erythropoietin. So for some reason, your kidneys are not able to generate the hormone EPO. This often accompanies a renal disorder. So if I already have issues with my kidneys, then that can cause my kidneys to not make proper amounts of EPO. So a treatment for that is to take a synthetic version of this hormone. Okay, so I'm not going to go through each one of these erythrocyte disorders, but I do want you to study them. Once again, I'm trying to make sure that these videos are not really long, so please study these in detail because I will be asking questions about this on the test. Okay. White blood cells, leukocytes. So they are the only formed elements that are complete, meaning that they have a nucleus and other structures that we find in normal traditional cells. When a person is healthy, we find that there's less than 1% in a whole blood sample, and their function is to prevent the body from being infected from pathogens. So in terms of how we group and categorize leukocytes, we can categorize them in a group called granulocytes. So these are leukocytes that contain a visible granules inside of them. They look like little seeds or dots inside of them. And the specific types of leukocytes that are in this category are going to be neutrophils, eosinophils, and basophils. We also have the other category of agranulocytes, meaning that they do not contain these visible granules. And the two leukocytes that fall in this category are going to be lymphocytes and monocytes. A mnemonic to remember: decreasing abundance in blood could be never let monkeys eat bananas. So in terms of the leukocytes that we find most abundant in our blood, from most abundant to least abundant, would be neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Okay, and here we have a diagram showing us the different types of leukocytes and their distributions that we find within our blood. So like you see on this diagram, the majority of our white blood cells are going to be neutrophils, and then we go on to lymphocytes, monocytes, eosinophils, and basophils. And here we have diagrams of showing what they look like under a microscope. So you will see these in lab, and this is what we see with our neutrophils. And you can see these tiny little granules, the tiny little dots that we find within them compared to the lymphocytes and monocytes. They do not contain these granules. So you can see in them side by side. I think it makes it a little easier to distinguish between the leukocytes that have the granules compared to the leukocytes that do not have them. The purple structures that you see within the leukocytes are going to be the nucleus or the nuclei, and some of the nuclei are lobed, like we find here in the neutrophils and the eosinophils. So let's get into what each one of these does and how they help the body fight different types of pathogens. So like we said before, the most numerous type of white blood cell will be our neutrophils. They're about twice the size of red blood cells. Their granules will stain with both acid and basic dyes, and they are typically the first white blood cell at an injury to repair it. They're very phagocytic, so they're going to be referred to as the bacteria slayers because they're the first ones there, and they tend to help to get rid of them very quickly. They're going to kill microbes by a process called respiratory burst, where the cell will synthesize a potent oxidizing substance like a bleach or things like that will help to get rid of bacteria. And then I think that's all I wanted to say about neutrophils. Eosinophils, they represent about only 2 to 4% of the leukocytes. We mostly find them when the body is undergoing an allergic reaction, if there is an asthma attack, and also if we have large parasites and the large parasites are causing some type of infection, we will see this white blood cell in abundance. And here we have an example of eosinophils. Basophils, they're the rarest type of white blood cell that we have in our bodies. They function similarly to mast cells. So remember from AMP1, our mast cells are going to be cells that are going to release chemicals in times of, or to initiate an inflammatory response. And they contain histamine, which is going to aid in them releasing these chemicals to cause inflammation. Think of them as the white blood cells that are going to work with mast cells so that it can let the body know there's an injury here and we need to repair it, or there's trauma here or an infection here, we need to repair it. And here we have an example of a basophil. And then we'll go into lymphocytes and monocytes. So lymphocytes are going to be the second numerous white blood cell. They're mostly found in lymphoid tissue, and we'll talk more about lymphocytes and the different types of lymphocytes when we get to the lymphatic system. They are going to be crucial in establishing our immune system. So when you think of someone's immunity, it's the lymphocytes in our systems that really establish this. And we have two categories of lymphocytes. And like I said, we'll delve deeper into this when we get to the system. But we have T lymphocytes or T cells. And then we have that are going to act against virus-infected cells and tumor cells. And then we have B lymphocytes or B cells, which will give rise to plasma cells and form antibodies. And then lastly, monocytes, they are the largest in size of our leukocytes, and they are going to leave our blood, enter our tissues, and differentiate into macrophages. So they're going to be actively phagocytic cells that are going to defend the body against viruses, bacterial parasites, chronic infections. And monocytes will actually also work to activate lymphocytes to increase and amplify an immune response. All right. In terms of the production and the lifespan of leukocytes, we'll go over this pretty quickly. So the process of producing white blood cells will be leukopoiesis, and it's going to, the production of these white blood cells are stimulated by two types of chemical messengers from red bone marrow and mature white blood cells. So we have interleukins that are numbered, and then we have colony stimulating factors. And they're named for white blood cell types that they stimulate. So for instance, if I stimulate a granulocyte like a neutrophil, then I'm going to be a granulocyte colony stimulating factor. So all leukocytes are going to originate from hemocytoblasts. Remember, all of our formed elements are going to start here. And the hemocytoblast stem cell will branch into two pathways, a lymphoid stem cell and a myeloid stem cell. So the lymphoid stem cell will specifically differentiate and form lymphocytes, and then the myeloid stem cells will differentiate and produce the other types of formed elements. For these developmental stages, and same with the red blood cells, I'm not going to say put these in order of how they're formed. This is just so that you have an understanding of it, but I do not want you to spend time and go, okay, so we're going to start out with the hemocytoblast stem cell, then we're going to go to myeloblast. I'm not going to ask you to do that, so you don't need to study it like that, but do have an understanding of it so that you're able to just understand the process. So I'll skip over the details of this because I'm not going to test you on it. This figure here shows us a really good overview of the process. So we start off with our hemocytoblast and our hematopoietic stem cell or hemocytoblast, and we'll differentiate into a myeloid stem cell or a lymphoid stem cell. So if we'll start with the lymphoid stem cell, then I'll differentiate it into a B lymphocyte precursor or a T lymphocyte precursor, and then eventually I'll distinguish and develop into a T lymphocyte or B lymphocyte. If we go over to the myeloid stem cell, then we will differentiate into a myeloid blast, three myeloblasts and a monoblast. The monoblast will eventually become a monocyte. One of the myeloid blasts will eventually become a neutrophil, and then a basophil and an eosinophil. So like I said, I'm not going to ask you step by step, tell me the details of how each one of these originates from a hemocytoblast to its mature form, but this just gives you an overview of how it's done. Once again, definitely study this section, but I'm not going to spend too much time on it for time purposes. All right. Hold on for one moment. I'm just going to pause this video real quick. Okay, so let's move on to platelets. So with platelets, they are fragments of a larger cell called a megakaryotype. They contain several chemicals that are involved in the blood clotting process, which we have serotonin, calcium, enzymes, ADP, and a plate-derived growth factor. In terms of function, platelets are in our bodies so that they can temporarily form a plug in a broken blood vessel so that it does not consistently leak out and cause a hemorrhage. Platelets are going to circulate, and they are kept inactive until they are activated and triggered to plug an injured or broken blood vessel. The process of forming platelets is called thrombopoietin. So anything ending in "eaten" is going to be the formation of something. And they are formed from the myeloid line from megakaryoblast, which is a stage 1 megakaryocyte. So we take this very large megakaryocyte, and we're going to break off segments of it that will eventually become our platelets. Platelets age very quickly, and they degenerate in about 10 days. So out of all of the formed elements, the platelets are going to have the shortest lifespan. So they're going to need to be replaced pretty often, which they are in normal, healthy adults. So here we see the formation of platelets. We start out with a hematopoietic stem cell that's going to differentiate into a megakaryoblast. From the megakaryoblast, it goes to a megakaryocyte. And then we get to the largest form of this megakaryocyte, and then we start to break off portions of this larger cell to form the platelets. Okay. Here is a summary of all the formed elements, table 17.2. This is a great table to study to give you an overview of what the formed elements are, how they function, what they look like, and their lifespan within our body. So I definitely would recommend this as a good table to study, to provide you an overview of each one of these formed elements and how they relate to the body. Okay, so hemostasis. This is the fast series of reactions for stopping bleeding of a broken blood vessel. So this is really going to talk to us and explain to us the process of clotting. So it requires clotting factors and substances released by platelets and injured tissues, and we have 3 steps involved. So step 1 is going to be a vascular spasm. Step 2 is going to be a platelet plug formation, and then step 3 is coagulation, or what we call blood clotting. So with step 1, vascular spasm, the vessel will respond to injury by vasoconstriction. So basically, we have injury to a blood vessel, the blood vessel will start to constrict and literally spasm. Vascular spasms are triggered by a direct injury to the vascular smooth muscle, chemicals that are released from endothelial cells and platelets, and then pain reflexes. This is most effective in smaller blood vessels, and it can significantly reduce blood flow until other mechanisms kick in. So the biggest benefit for vascular spasms is the reduction of blood flow, because if you have a break in a blood vessel, of course, we don't want to lose a ton of blood. So these vascular spasms help to slow down blood flow so that we're not losing as much blood until we can get clotting materials there to temporarily stop and, well, permanently stop blood flow. Step 2 is platelet plug formation. So platelets are going to stick to collagen fibers that are exposed when the vessel is damaged. Platelets do not stick to intact vessel walls because the collagen is not exposed. But when we have a break in our blood vessels, we have collagen that's exposed, and so platelets can stick to those and start to form a plug. Also, prostacyclins and nitric oxide are secreted by endothelial cells to prevent platelets from sticking to non-damaged portions of the vessel. And then we have von Willebrand factors that will help to stabilize the platelet collagen adhesive. So think of this as like a glue that's going to help, the platelets and the collagen portions of the blood vessel really stick together and adhere to each other. So when activated, the platelets will swell, they become spiked and sticky, and they release chemical messengers. So some of these chemical messengers are going to be ADP. That's going to cause more platelets to stick and release their contents. And remember, with blood clotting, this is a positive feedback mechanism. So this is one of those factors that's going to stimulate more platelets to come and plug until the clot is formed. Serotonin and then thromboxane A2 will enhance vascular spasms and platelet aggregation. So these chemical messengers are going to be the positive feedback mechanism side of blood clotting. Like we said, or like I just said, it's a positive feedback cycle. So as more platelets stick, they release more of these chemicals, ADP, serotonin, so that we can have more platelets to stick and release more chemicals so we can further cause our plug to form. Platelet plugs are fine for small vessel tears, but large breaks in vessels need an additional step. So coagulation is the formal term for blood clotting, and it reinforces platelet plug with fibrin threads. So blood clots are effective in sealing larger vessel breaks with this particular processes, having platelet plugs with fibrin threads, because the vessel is larger, so we need more assistance. Blood is transformed from liquid to more of a gel substance, and then we have a series of reactions that uses clotting factors that's going to mostly be composed of plasma proteins. And then coagulation itself occurs in 3 phases. So the first 2 phases, vascular spasms and platelet plug formation, those 2 phases wrap up blood clotting for smaller vessels. But if there's a break in a larger blood vessel, we're going to need to go through the 3 phases of coagulation to plug the break. So here's the event of hemostasis, and I will just skip over these since we've already talked about that. So phase 1 of blood clotting, we have 2 pathways to prothrombin activator. So this is going to be initiated by either an intrinsic or an extrinsic pathway. In a lot of cases, we're going to use both pathways, and this is going to be triggered by a tissue damaging event. So we've got a cut in a large blood vessel. It's going to involve a series of procoagulants, and each pathway cascades toward and ends with the activation of factor V, which is a particular type of substance used in blood clotting. Factor V will then complexes with calcium, platelet factor 3, and factor V to form prothrombin activator. So if we're using the intrinsic pathway, it's called intrinsic because the clotting factors are present already within blood. And this is triggered by negatively charged substances such as activated platelets and collagen or even glass of a test tube. The extrinsic pathway is called extrinsic because factors needed for clotting are located outside of blood. So this is triggered by exposure of tissue factor, also called factor 3, and this bypasses several of the intrinsic pathway steps, so it's a faster pathway. So for this particular section, I'm not going to test you in detail on these steps, so I'm going to skip over this, but I want you to know and have a good summary of this particular process of blood clotting. Phase 2 is going to be the pathway to thrombin. So prothrombin activator will catalyze or speed up the transformation of prothrombin to active enzyme thrombin. And thrombin will convert fibrinogen into fibrin, because remember, in larger blood vessels and in the process of trying to clot those, we need fibrin in addition to our normal blood clotting factors. So fibrin strands form the structural basis of a clot. Fibrin causes plasma to become a gel-like trap, which will catch formed elements. And fibrin kind of looks like, when you look at it on a microscope, I mean, it almost looks like a web that's going to kind of hold, or it actually looks more like a mesh that's going to actually just seal everything together so we can really solidify the clot and help to really close off the break in that larger blood vessel. So thrombin, along with calcium, activates factor 8, which is a fibrin stabilizing factor, which is going to cross-links the fibrin, so form that mesh-like structure and strengthen and stabilize the clot. And then anticoagulants are factors that normally dominate in blood to inhibit coagulation. So if somebody has blood that clots too quickly, we're going to give them an anticoagulant so that their blood does not clot because it clots too quickly, which can cause blood clots. Okay, so here we have a diagram, a scanning electron micrograph of erythrocytes trapped in a fibrin mesh. So like I said, fibrin is going to be this mesh substance that we see here that's going to form or help to form the clot. So we're going to trap these red blood cells so that they can't flow out so that we can clot that broken blood vessel. Pretty neat, right? And then here is table 17.3 that shows all of the blood clotting factors. I'm not going to test you on this individually, so I don't want you to spend too much time trying to memorize each one of them and their nature, their source, and their pathway and function. Like I said, I just want you to have an overview of why we need blood clotting factors, how they work to clot small blood vessel injuries as well as large ones. Okay, clot retraction and fibrinolysis. So a clot must be stabilized and then removed when the damage has been repaired. So clot retraction is going to involve actin and myosin and platelets, and they contract within 30 to 60 minutes. Then the contraction pulls on fibrous strands and squeezing serum from the clot. The serum is plasma minus the clotting proteins. And then it draws ruptured blood vessel edges together. So this is the process that we're using to remove the scab when the area is healed. So vessel healing, the vessel is healing even as the clot retraction occurs. And then we have a platelet-derived growth factor that is released by the platelets. So this is going to stimulate the division of smooth muscle cells and fibroblasts to rebuild the blood vessel wall. And then we have vascular endothelial growth factors that will stimulate endothelial cells to multiply and divide so that we can restore the endothelial lining of our blood vessel. Fibrinolysis is a process whereby clots are removed after the repair is completed. This begins within 2 days and continues for several days until the clot is broken down. Plasminogen is a plasma protein that is trapped in a clot. It's going to be converted to plasmin, which is a fibrin digesting enzyme. And so I think of it like when I get an injury and you know, let's say let's say it's a pretty, bad cut. I didn't have to go to the hospital and get, stitches, but it's pretty bad cut. You'll notice that maybe within a week or so, your scab might start to lift. And this process that we're talking about is the process of how that scab is lifting and being removed to where, when you're done or when it finally is lifted and gone, that area is pretty repaired. Your skin is back intact. You might have a little bit of a scar, but the area is repaired. Okay, factors that are limiting normal clot growth, I'm not going to test you on this section, so I am going to skip over it. In terms of disorders of hemostasis, definitely want you to read over this. And if you have questions about any of these disorders or these imbalances, please let me know. Like I said, for video purposes, some of these videos can be so long, so I really try not to spend too much time on it. But please send me an email if you're ever reading over these sections and you're just kind of like, can you explain this a little bit more? I definitely don't mind doing that. And if you actually want me to discuss these in the lectures and you don't mind the videos being longer, then let me know because I will discuss them. Okay, blood transfusion. So this is a topic that if you're going into the health field, you really want to understand this because as we all know, blood transfusions can be harmful and potentially even fatal if they're not done right. So cardiovascular system minimizes the effect of blood loss by reducing the volume of affected blood vessels and stepping up the production of red blood cells. So the body can compensate for only so much blood loss. So if I am hemorrhaging and I'm losing tons and tons of blood, especially very quickly, my body cannot replace those red blood cells like that. If I donate blood and I don't have any traumas, after my blood donation, then yes, my body can replace those red blood cells that I lost, and I really won't see a disruption in normal body function. If we lose about 15 to 30% of blood, this causes pallor and weakness. But if I lose more than 30% of blood, this can lead me into severe shock that can be very fatal. So death from shock may result from low blood volume, just not having enough blood to circulate through the body and deliver the oxygen, nutrients, and so forth. Volume must be replaced immediately, and we can do that with a blood transfusion. So whole blood transfusions are only used when blood loss is rapid and substantial. So, a patient is on the surgery table and they start to bleed out. A woman is giving birth, and in the process of giving birth, she starts to hemorrhage. We need to do blood transfusions at that point because a person is losing blood very rapidly and we need to replace it. So infusions of packed red blood cells, and with these packed red blood cells, the plasma and the white blood cells are removed. So the patient is only getting red blood cells. They are preferred to restore the oxygen carrying capacity because the biggest consequence to losing too much red blood cells is the distribution of adequate amounts of oxygen to your tissues. Blood banks usually separate donated blood into components, and the shelf life of blood is about 35 days. So, our Red Crosses or our local blood banks, they're not able to store blood indefinitely. And in most cases, they're not even able to store blood at all because there's always such a need for blood. Human blood groups of donated blood must be determined because transfusion reactions can be fatal. And so that's why we get into blood typing, and that's why understanding blood types and blood typing is very important. So we have, for humans, we have some blood groups. Red blood cells, so our red blood cells are going to have antigens on them. An antigen is going to be a receptor that is going to let our bodies know if a cell is a self cell or if a cell is foreign. So it's this actual receptor that resides on our red blood cells and really all of our cells to distinguish between cells that are normal and normal to our bodies and then cells that are not. So red blood cells antigens are referred to as agglutinogens because they promote agglutination or cells sticking together. Mismatched transformed or transfused blood is perceived as foreign and may be agglutinated and destroyed. So what happens is if I'm given the wrong blood, that can cause my red blood cells to clump together and agglutinate, which would cause the cells to burst. And that is what can lead to the fatal reaction to a bad blood transfusion. So humans have at least 30 naturally occurring red blood cells antigens. the presence or absence of each antigen is based on how we classify blood types. Some blood groups are only weak agglutinogens, and so we don't really talk about them because their reactions or non-reactions are not too detrimental to the body. But our antigens of our ABO groups are the ones that are most reactive and can be most fatal, especially if a person is given a wrong blood type. So ABO blood groups are based on the presence or absence of two agglutinogens, antigens A and antigens B. And these antigens are found on the surface of our red blood cells. So if you are considered a type A, having type A blood, this is because you have only a agglutinogen or a antigen on your red blood cell surface. If you are considered to have type B blood, then you have only the agglutinogens on your red blood cell surface. If you are type AB, then that's because you have both agglutinogens on your red blood cell surface. And then if you're type O, that means you have neither of these agglutinogens on your red blood cell surface. So I'm type O, I have no antigens on my red blood cell surface. Okay, so blood may contain preformed anti-A or anti-B antibodies, and we find these antibodies or agglutinins in our blood plasma. They act against transfused red blood cells with ABO antigens not present on the recipient's red blood cells. So if I am type A blood, then in my plasma, I have anti-B antibodies or anti-B agglutinins. If I'm type B blood, I have type A antibodies in my plasma. If I am type AB blood, I have no antibodies in my blood plasma. And then if I'm type O, I have both A and B antibodies in my plasma. The anti-A and the anti-B form in blood at about 2 months of age. So when we're around 2 months of age, and then they reach adult levels by the time we're 8 to 10 years of age. So here we have a diagram showing us the blood groups, the particular antigen or the particular agglutinogen that we find on the red blood cell surface. It also tells us the plasma antibodies or the agglutinins that we would find in the plasma. And here we have a diagram that actually shows us what they would look like. So this is an excellent table to study, especially if you're not really familiar with blood groups and how they work and what that means. I'm not going to ask you the frequency of blood groups across the U.S. population. That information is there just as an FYI. But I do want you to understand blood groups, the agglutinogen or the antigen that would be on the red blood cell surface. I want you to know the plasmas the antibodies that we find in the plasma, and I want you to know what blood that person can receive. So if I am type AB blood, or if I have type AB blood, that means on my red blood cell surface, I have agglutinogens A and B. I have no antibodies in my plasma, and I can receive blood from anybody. So I'm considered the universal recipient. If I'm type B blood, that means that I have type B agglutinogen on my red blood cell surface. That also means that in my plasma, I have anti-A antibodies, and I can receive blood from only type B or type O donors. If I'm type A blood, I have A agglutinogens on my red blood cell surface. I also have anti-B antibodies in my plasma, and I can receive blood from only type A and type O donors. And then if I'm type O blood, I have no agglutinogens on my red blood cell surface. I have both anti-A and anti-B red blood cells on the surface, in my plasma, and I can only receive blood from O. But I'm considered the universal donor because I do not have any antigens or any agglutinogens on my red blood cell surface. Okay. Whew, that's a lot. Okay, so let's get into the RH factor, the RH blood groups, because this is going to determine if you are blood type positive, blood type negative. So the positive and negative is going to be indicative of the presence or absence of this RH group. So there's 52 named RH agglutinogens or RH factors. C, D, and E are the most common, but like I just said there's 52 of them. So Rh positive means that you have a presence of what we call the D antigen, or this Rh factor, one of the 52. About 85% of the American population is Rh positive, meaning that you have one of these Rh factors on your red blood cells. Anti-Rh antibodies are not spontaneously formed in Rh negative individuals. So anti-Rh antibodies form if an Rh negative individual receives Rh positive blood, or an Rh negative mom is carrying an Rh positive fetus. So this gets into a discussion as to why an Rh negative mother would need to take RhoGAM, and we'll talk about it in just a moment. Second exposure to a Rh positive blood will result in a typical transfusion reaction. So hemolytic disease of a newborn, also called erythroblastosis fetalis, occurs only in Rh negative moms who are carrying an Rh positive fetus. So let's talk. So I'm a mother, I am Rh negative. The father is Rh positive. So we have a child who is Rh positive, okay? This is my first child, so I give birth and the child is fine. Through the process of pregnancy and labor, my fetus's blood crosses the placenta and gets into my blood, okay? So since I'm Rh negative, that means I do not have this Rh factor on my red blood cells. These positive Rh factors are going to cause my body to make antibodies for this Rh factor, because my body is going to recognize this positive Rh factor as foreign, and so we're going to create antibodies so that we can fight it off, right? Because my body's considering it as foreign. So I get pregnant again, not knowing that this has occurred, and my child dies in utero. Okay, I get pregnant again, my child dies. Let's say I have 4 pregnancies and all of them die. Why are all of them dying when I was able to have a successful child the first go around? So what's happening is, when the Rh negative mom's body makes antibodies for this Rh factor, when she gets pregnant again, if she does not take the shot called RhoGAM, the RhoGAM serum, it's going to contain anti-Rh that will prevent the Rh negative mother from being sensitized and forming these antibodies, okay? If she does not take this shot to prevent her body from making antibodies to the Rh positive factor, when her body makes those antibodies will then travel into the fetus's blood, and the antibodies will bind to these receptors on the fetus's red blood cells. When it does that, it will cause the red blood cells to agglutinate and stick together and eventually lyse and break. So now the fetus's blood, or the fetus's red blood cells, are bursting. And if the red blood cells are bursting, there's no oxygen flow, there's no nutrient flow, and that child's going to die. So it's very important to, first of all, when a woman comes in and she's pregnant, to do some blood testing. So if the woman does not know her blood type and the father does not know his blood type, it's important to know those blood types so that we can determine if there's a chance that the fetus is going to be Rh positive, especially if the mother's Rh negative. Now, if the mother is Rh positive and the child is Rh negative, there's not going to be an issue there, because there's no way that her body's going to form antibodies to the positive Rh factor, because she's Rh positive. And there's also no issue if both the parents are Rh negative, because if both parents are Rh negative, the child's going to be Rh negative as well. It's only an issue if the mother is Rh negative, the father is Rh positive, and then that child ends up being Rh positive. That's when we have this potential of this illness occurring. But luckily, like I said, doctors are now aware of this. We have a serum that we can treat, or that can be used for treatment, so that the mother never has to go through the horrible trauma of having a child and wanting to have more children and not being able to have them. Okay, so I do want you to understand this process. This is definitely going to be on your next test. Well, not your next test. Well, actually, yes, your next test, because the first exam will cover this chapter too. So you definitely want to understand that. If for some reason you don't understand this, definitely let me know. and I don't mind explaining that to you again. In terms of transfusion reaction, so this occurs if mismatched blood is infused, the donor cells are attacked by the recipient's plasma agglutinins or antibodies. And like I said before, when we were talking about the hemolytic disease of a newborn, the same thing occurs in a transfusion reaction. So if I am type A and I'm given type B blood, remember in type B blood, what type of antibodies do we have? We have type A antibodies. Those antibodies for type A are going to be able to fit perfectly on my A agglutinogen. And so when they do that, they're going to bind to my agglutinogen, cause my red blood cells to clump together and then lyse, break apart. So when my red blood cells lyse and break apart, that's going to result in a diminished oxygen carrying capacity. It's going to decrease blood flow past a blocked vessel, and it's also going to cause hemoglobin and kidney tubules that can lead to renal failure. Because if we have too much hemoglobin being filtered through the renal tubules as waste products, it can lead to renal failure because it's too much waste trying to be filtered out by the kidneys, and our kidneys can't handle it. So if someone is having a transfusion reaction, symptoms can include fever, chills, low blood pressure, rapid heartbeat, nausea, vomiting. So the way that we can treat it is preventing kidney damage with fluids and diuretics to wash out the hemoglobin so that we don't have this buildup of hemoglobin in our kidneys. For, like we said before, type O is going to be our universal donor, and type AB is going to be the universal recipient. And autologous transfusions occur when a patient will pre-donate their own blood, so that if, like for instance, let's say I'm going into a surgery, I don't want to receive anybody else's blood, but I also want to have blood available to me that just in case I need a transfusion. So I can pre-donate my blood, the hospital will store it, and then if I do need a blood transfusion, I can just get my own blood and have the least complications to a transfusion reaction. Okay. Blood typing. So a donor blood is mixed with antibodies against common agglutinogens. If an agglutinogen is present, the clumping of blood will occur. So when you get in lab, if you haven't already done this before, you will actually be able to practice this, and you will take fake blood, not real blood, but fake blood, and you will mix the fake blood with different antibodies, and you'll be able to see this blood clumping together. So if clumping were to occur, then the agglutinogen for that blood is present. Blood type for ABO and for RH factor is going to occur in the same manner. So if we see clumping for that particular agglutinogen, then we know that that agglutinogen is present. And cross-matching is when typing between a specific donor and a specific recipient occurs. So let's say I'm in need of blood, and my brother says, okay, am I a match? We call that cross-matching, where we're going to see, are our bloods compatible? And we do this by mixing the recipient's serum with the donor's red blood cell, and then we mix the recipient's red blood cells with the donor's serum to see if it is a cross-match. So here we have a diagram showing us blood typing of ABO blood types and how they look. So this is what you will see when you do this activity in lab, if you haven't already done it before. So if someone is type AB, they contain the agglutinogens A and B on the red blood cell surface. So when we mix the blood sample with these anti-A and anti-B serums, we'll see clumping on both anti-A and anti-B, meaning that this blood sample has both agglutinogens for A and B. If someone is type A, then when we mix the blood sample with the anti-A serum, we'll only see clumping for anti-A, but we won't see it for B. So this lets us know that this blood sample contains agglutinogen A on the red blood cell surface. If we mix a sample of blood with the anti-B serum, we don't see clumping with the anti-A, but we see it with anti-B, meaning that that blood sample contains the agglutinogen B. And then if we were to mix these red blood cells with the anti-A and anti-B serums, but there's no clumping at all, then we know that this blood type is O, because there's no clumping, because there's no agglutinogens on the red blood cell surface to cause clumping. Okay, once again, if you have questions about blood typing and you still are kind of foggy on it, definitely send me an email and I will definitely help explain it to you a little bit more. Alrighty, so some diagnostic blood tests. We can examine blood that can yield information about a person's health. So if there's a low hematocrit, we'll see that in cases of a patient being anemic. We can do blood glucose tests to check for diabetes, and leukocytosis can signal some type of infection because we've got presence of leukocytes. We can use a microscope to examine blood, and that can help us to see if there's issues with the actual size and shape of our red blood cells. So if we see any type of abnormal size, shape, or color, this can indicate a specific type of anemia as well. So the differential white blood cell count looks at the relative proportion of white blood cells. And so, for instance, if we see a whole bunch of eosinophils in a blood sample, we could think, okay, this person could have had an allergic reaction, they could have had an asthma attack, or they could have a parasite, because we know that these white blood cells are present based on these particular types of illnesses or pathogens. A prothrombin time and platelet count will assess hemostasis, so the process of blood clotting. CMP, which is a comprehensive medical panel. This occurs when a blood chemistry profile, it's a blood chemistry profile that checks various blood chemical levels. So if we see any abnormal results, that could indicate a liver or kidney disorder. And then a complete blood count checks for formed elements, hematocrit, and hemoglobin levels. So in terms of the developmental aspect of blood and how it develops and is processed as we are forming, fetal blood cells form in the yolk sac, liver, and spleen. Red bone marrow is primary hematopoietic area by the 7th month. So by the time a fetus reaches 7 months of age, their primary hematopoietic area is going to be their red blood cells, their red bone marrow. Blood cells develop from mesenchymal cells, which are called blood islands, and the fetus forms hemoglobin F, which has a higher affinity for oxygen than hemoglobin A. That's formed after birth. So hemoglobin F is going to be the specific type that we find on fetal red blood cells, and that's so that the fetus can have a higher affinity or attraction for oxygen, since the oxygen that the fetus is going to get is going to come from the mother. Once the child is born, the hemoglobin turns to hemoglobin A, because at that point, the child is able to breathe and take in their own oxygen, so they don't need a hemoglobin molecule that has as strong an affinity for oxygen. Some blood diseases that can occur as we age include leukemia. So these are any types of blood cancers, more specifically involving our white blood cells. We have anemias and clotting disorders. And they're usually going to be precipitated by some type of other disorder that occurs with our heart, immune system, or our blood vessels. And that is it. I hope that this tutorial was helpful, and I'm sorry if it was long. Some of these chapters are long, and like I said, I'll try to cut out information that I feel that you can study on your own. But yes, let me know if I need to clarify any material that was presented here, and hopefully I will see you in the next tutorial. Have a good one.